Hello, welcome everybody. I am Dr. Cortese from Milano. I'm really proud to start this session in collaboration with the DCB Academy that I'm representing here. We have a great panel here to share our knowledge and enthusiasm about DCB. This guy here, Fari Fuladvan, is a good friend of mine. We've worked together until a couple of years ago, but maybe in the future, for sure we will work together again. And he wasn't a believer about DCB, but now he is. Now, this is why he's here. So Fari, you know him. He's very famous here and also around the world. Then we have Dr. Maksudov and Dr. Amit Munjal from DCB Academy. He's a fellow of DCB Academy, but he's from India, so now he's late. It's nothing particularly strange. Join us, please. So it's a real pleasure to be here. I started my collaboration a lot of years ago with Bulgaria, with GIZE. I was here opening a cath lab in Pleven, and I was in another cath lab somewhere else. I don't remember actually the name of the city because many years have passed. But I could see the good quality and the enthusiasm in interventional cardiology. We didn't speak about DCB at that time. And now I've been told that DCB is quite important in the numbers here in the country. So the goal of this session is to improve and boost your belief, because we strongly think that this technology may have big advantages in some lesion setting, in some patient setting as compared to stenting. So now it's my pleasure to invite here Fari Fuladvan with just the boring presentation about the technological backbone of DCB, but it's a very important presentation about the technology.
Bernardo, thank you very much. Hello to everybody. Well, really, that my presentation is very boring. It was boring to prepare it, and probably will be boring for all of you. How can I move the slides? Move to second screen. Ah, okay. Well, I think this was the first slide. A drug-coated balloon is a non-stent, just an introduction, non-stent technology in which the vessel wall receives the effective homogeneous delivery of anti-proliferative or any type of a drug from an inflated balloon. It is done to restore the lumen vascularity, to treat atherosclerosis, in-stent restenosis, and reduce the risk of late thrombosis. This is very important, to reduce the risk of late thrombosis without implanting a permanent object. The balloon technology relies on the concept of targeted drug delivery, which means to deliver the drug exactly at the place that we want, exactly at the place of the stenosis, which helps in rapid healing of the vessel and prevents the proliferation of smooth muscle cells. So the rationality of using DCB balloons derives mainly from the limitations of death. You know that the initial enthusiasm of reducing the incidence of restenosis that we achieved after death was weakened by some reports indicating the risk of late thrombosis after intimation of the releasing of the stent, but also of the risk of bleeding in those patients that we are treated with death because of the double antiaggregation. DCB ensures even which means equal distribution of the drug for a very short period of balloon inflation and short contact of the balloon with the vessel wall, and do not increase the risk of chronic inflammatory reactions. So a lot of studies are looking about the drug-eluting or drug-coated balloons. A lot of studies we can see here, huge amount of materials. But the research work in the field of DCB in general focuses on the continuous improvement and focuses on the material used to make the balloon, the type of medications used for coating, and the coating technologies. So the balloon materials should have adequate flexibility. It must be a good balloon to deliver the balloon very easily, high mechanical strength, and be thinly walled, because sometimes you need to fold 3 to 7 times to inflate and deflate the balloon. So the balloon must be a good quality balloon. They are constructed of cross-linked different materials like polyethylene, polypropylene, and you see a huge amount of the different materials that gives different characteristics and compliance of the balloon. About the coating material, which is a very important thing, polymeric materials are used to coat the balloon to hold the drag. So the drag you put on the balloon, but you need something to keep the drag for controlled release. Polymers adhere to the balloon before inflation, and then after the inflation attached to the vessel after the inflation to decrease the thrombosis. Any material which is biocompatible, biodegradable, and bioabsorbable with an adhesive nature can be used as a matrix to coat the drag coating balloons. So I will run very quickly in the different type of the coating materials. Various polymers have been used to date. Biodegradable polymers such as methacrylate, acrylate, polyethylene, biocompatible polymers such as carbopool polymers, carbopoloxamer, gels, and different. You see how many different materials are used as a coating polymers. Bioadhesive polymers, for example, such as PLGA, this is a very famous one, proteins, carbohydrates, and so on. Then we have the second part of the balloon, which is the therapeutic substances. Their agents can be antiplatelet, anti-inflammatory, anti-prophylipidemic, anti-proliferative, and antithrombotic. But among all of these agents, paclitaxel and sirolimus are the preferred drugs to be applied to the balloons. We have those two drugs. The drug release must be maintained in place to achieve a therapeutic effect. Moreover, no local or systemic toxicity may occur, and the delivery mechanism should not simulate restenosis. It's important that controlling the release of drug into the wall of water-held vessel when inflating the balloon is very important into the DCB design process. The critical parameter of the safety and efficacy of the drug is that it should be released at a desirable rate and without the loss of effectiveness. So we have here the list of different types of drugs that can be used, but as I said, taxans, paclitaxel, and sirolimus are the mostly used drugs in the drug-eluting or drug-coated balloons. So excipients, what is the excipient? Excipient is another substance that is used in the drug-coating balloons that keeps the drug inside of it and then goes toward the wall. Currently, DCB developers are proposing to use various biocompatible excipients to cover balloons to transfer drugs to the arterial vessel more efficiently. There is a variety of excipients used today as iopramid, urea, and so on. Coating can be composed of several excipients, not only one, several excipients, and can even be applied through layers approaches acting to protect drug loss, which is very important. When you pass with the balloon through the catheter, you can lose the drug. So to protect drug loss during tracking, to modulate drug burst, so to modulate the releasing of the drug, and by this to provide a controlled drug release. Second thing, the method of placing the drug on the balloon surface can be varied. This depends on the model of the balloon and the technology used. There can be different types. Balloons with the drug applied in an uniform form, balloons covered with a protective layer preventing the premature releasing out of the drug, and balloons in which the drug is combined with an excipient facilitating its distribution to the surface of the vessel. So I will run very closely in this slide, skip it. And here you can see the different type of the excipients, bioadhesive, hydrophilic, lipophilic, antioxidants, and different form of, and their role in the different type of the balloons. So another most important part of the balloon production is the coating technology. Balloon coating can lead to better design and improved outcomes. Even the profile of the balloon can be changed. So we have some balloons that very easily pass, some are not, depends on the coating procedure. There are different methodologies for loading the drug onto a balloon, like spraying, dipping, micropipetting, applying nanoparticles, and even imprinting the drug medicine onto the rough surface of the balloon. Here you can see very the schematic representations of the coating techniques like spray coating and so on. And then the type of coating, hydrogel coating, I will just say that the third point, that the balloon is coated with 3 layers, namely the outer, middle, and inner layer. And the outer, the inner layers are occlusive layers. They keep in the middle the middle layer that is not in contact with the catheter and contain the therapeutic agents. Then we have the polymer-free coating, because, as we know, some biodegradable polymers and their decomposition during the degradation process can irritate the surrounding tissue and create the restenosis. So the polymer-free coating is another type of the coating that is used in the balloon to reduce this irritating risk. Then we have the immediate release coating, a type of coating containing a biodurable polymer with a bioactive agent, which upon exposure means very, very quickly showed the burst release of the bioactive agent. And then bioadhesive coating, another type, I'll run it, multiple layer coating with 2, 3 layers, and multiple layer even with the 3 type of layers. So you can see here very quick representation of the coating technologies of the first generation, second generation, and third generation, which is the sirolimus stent. I think it's Magic Touch, the stent. Types of different coating you see. And then as a conclusion, among the active agents, paclitaxel and sirolimus are the preferred drugs that be applied to the DCB, and the controlling the release of drug into the vessel wall while inflating the balloon is a vital issue in the drug coating balloon design. So thank you very much for your attention for this very boring lecture. Thank you.
We can have the discussion after my talk. I think I have a very good question about the polyethylene glycol for you, but maybe later.
Okay.
Yes, you can answer yourself. Okay, so what shall I do here? It's not touch. All right. So the second part will be, more clinical. I would like to share with you and show you some cases on what are tips and tricks. Why 9 minutes? Should be 10, but it's okay. Tips and tricks with DCB angioplasty, because you can be sure that if you don't apply these tips and tricks, the outcome on the long term of a drug-coated balloon, this is true also for stents, actually is not going to be very good. Because these are not the dilatation tools, but they are devices that serve just to release the drug in the end, after you have achieved a good lesion preparation. So I have the same issues as Fari. Yeah, so I will use this. So this is the team of DCB Academy. I'm really happy that this team, which consisted of 8 persons 6 months ago, now it's increasing. Now there are 2 others gathering the group, and I'm really proud because we are producing a good amount of clinical studies and papers. We have done 2 publications this week about DCB that you will see in PubMed soon. So I'm really, really proud of this group. The difference between a stent and a drug-coated balloon is quite clear in terms of respectfulness for the anatomy of the vessel. A DCB is much more respectful theoretically, but we have seen this in some studies also published this year, like the long-term follow-up of Piccoletto 2, that there is a stop of the events after 12 to 15 months after DCB angioplasty. Whereas with drug-eluting stents, we will see later in another slide, these events unfortunately go on forever. Because we are implanting a prosthesis that will stay there forever. Okay? With DCB, it's not like that. So this is a case that I just received yesterday by a collaborator. It was very nice to show. This is a center in Legnago, in the northern part of Italy. It's a highly calcific LAD, diffuse disease. So I don't think that putting many stents with a chemin de fer here is a good option for our patient. So correctly, they decided to do an aggressive lesion preparation. They used rotablation, they used 2.0 and 2.5 predilatation balloons, and then in the end, they delivered the drug, in this case, paclitaxel. And this is the final result, which is very, very nice, and this is the angiographic outcome after 5 months, with some lumen gain. That is something that you will see with paclitaxel, but you don't see with sirolimus. And look at this. It's a very nice result after 5 months. And this is another case of a multivessel disease, diffuse proliferative, not highly calcific, but proliferative disease. So also here, with these 3 bifurcations, diffuse disease, CTO, I don't think that putting stents all around would be a good solution for our patient. So we should just place stents where they should be. So we started predilating the lesion. It takes time. We have to use semi-compliant or non-compliant or scoring balloons. In this case, the lesion did well after predilatation, so we didn't need to use specific calcifications, tools for calcifications like ROTA or IVL, but we do it quite often. So after this lesion preparation, you can just deliver the drug. We deliver the drug here in diagonal 2. We deliver the drug here, proximal LAD, and diagonal 1, and then mid LAD. This was the result. A nice dissection, not a flow-limiting one. And then we have to take an orthogonal view just to assess if we have recoil after a few minutes. This was the result, which was really nice. Then 2 days later, we managed to do the CTO. We crossed it quite easily. It wasn't a complex one. We have another presentation about CTO later. And then in the end, we decided also here to go for a full DCB. Again, orthogonal view, not flow limit in dissection, that's it. You don't need to go on. So which are the most important do's with the DCB angioplasty, in my opinion? First of all, you should know your device well. You should ask for the animal studies about this device and for the clinical program. My suggestion is to use devices with a good clinical program, okay, not to use. It was quite easy in Europe to come out with a new CE mark device previously. Now it's a little bit more complex, but many DCB do not have a good clinical program. Then you should know your patient very well. So you should know and interpret if the patient has cancer, if the patient had previously a bleeding. So these are patients that are particularly fit for a DCB angioplasty. Then you have to assess your lesion well. Not the easy lesion, but the complex one should be assessed well, also with intravascular imaging. The penetration of intravascular imaging in our cath labs has increased a lot in the complex lesion setting, for stenting, but also for drug-coated balloon. Then you have to prepare it. You don't have to spare any tool to prepare the lesion. We have seen a case with ROTA. We used IVL. Something happened to the slides, okay? And you have to prepare it rigorously. This stage is the most important DCB, even if you have not opened your DCB yet, in the DCB angioplasty, because it takes time, a little bit more than for stenting. And then when you apply the drug-coated balloon, you have to be gentle. You don't have to go from 1 to 12 or whatever very fast, but inflate it quite gently, because we know that dissections are good for the penetration of the drug, but nasty dissections are not good because we have to implant a stent in a bailout fashion. And then long inflations. Long inflations are creating what I usually say a sort of scaffolding effect of the drug-coated balloon. Okay, we don't want to implant a scaffold, so we go with longer inflations, 60 seconds minimum. If the patient tolerates it, even more. And this is the case that I showed you before. And then, again, after that lesion preparation, after you have achieved that result, you have to go with a DCB if you have received, done a good lesion preparation, or with a stent. Then you assess the results in 2 views. You stop for a few minutes, take a coffee or tea, I don't know here, maybe tea. In India it's tea, in Italy it's coffee, but it's the same. And then you reassess it after a few minutes. Orthogonal view, that's it. If you don't have recoil, I mean 30% recoil is accepted, more than 30 only in a very complex lesion setting. It can be accepted maximum 50%, that's it. You don't need to implant stents. When should you implant stents? Only in case of acute recoil or very long or flow-limiting dissection. So the presence of a dissection is not an indication to implant a stent, but only if it's flow-limiting. So what shouldn't you do with a DCB angioplasty? Decide to use a DCB at the beginning. You may think about it, but not decide, because you have to prepare the lesion and assess it. You don't have to struggle in that direction, because we have very good working stents. I can repeat it, we have very good working stents, we can use them, but we have to avoid using them in too many patients and in too many cases. So don't be rigid. Pay attention not to touch the device. Tomorrow we will have a live case. I will show you how not to touch the DCB. Take care at transit. Don't use a DCB as a dilatation tool. I already said this. And in case of bailout stenting, you don't need, okay, you did 60 millimeter, 70 millimeter LAD. Good result, some recoil. You don't need to pave 60 millimeters. You need just to put a short stent where you have recoil, and that's it. This is another case that we did a few years ago during a proctorship. It was an acute coronary syndrome patient. Then we prepared the lesion with a non-compliant. We use here a sirolimus coated balloon. Look at this, nice, huh? Yeah, but the flow is good. So I stopped the physician and I asked, okay, it's your decision, but I wouldn't put a stent here. And he didn't do it. We assessed it in an orthogonal view because these dissections sometimes are associated with recoil, not in this case. Here the section is even better. And after a few months, he sent me the angiographic follow-up because in these cases I suggest to do angiographic follow-up. Look at this, total healing. In this case after sirolimus, but with paclitaxel, it's the same of the dissection. Look at this, very nice. So I'm finishing this. We have done a good quality, hopefully, of data, because in this book, we are gathering all of the most experts in the world in this technology. The book was edited in 2019. We have published this book this year for a non-stent approach in our complex patients with these physicians that are, again, among the most experts in the world, and next year it will come the re-edition of the Springer book. Thank you for your attention.
So I think as a program, we have some minutes for discussion, and from the audience, if there are some questions about these tips and tricks of the using drug-eluting balloon.
Also about the first presentation.
Also, no, the first presentation, you can leave it. So, no, questions, anyway, questions from the audience. I have one question about the delivery of the balloon through the catheter. Generally, when we enter a device inside of the Epsilon connector, we keep the valve just a little bit open, and after that close the valve and go with the device, balloon or stent. And your suggestion is to keep the valve open during the whole time, or?
Yeah, during the transition of the balloon. This is very important, as you said. It can be an issue when you do peripheral. If you do a long SFA with a long DCB, you may lose some blood. Okay, we know this, but otherwise we have seen scratching the drug from the balloon if we don't pay attention at this stage.
Well, I have to say something that with that right coronary artery, with this dissection, probably most of us are going to put a stent, and there is not a studies that says the stent is better or not. We put a stent because we want to go to home and to sleep and will not be called during the night for the occlusion, but probably Bernardo will say the risk of thrombosis after such a dissection without stent probably is irrelevant.
That's it. I had one case of acute occlusion after DCB. It was, I always cite this case, also in India I cited it. It was 2014, but it was my mistake, because I just did the pre-dilatation, good, DCB inflation, but just one shot in the end, one final angio, not the orthogonal view. So the patient had chest pain after a couple of hours. He was still in the discharge room behind the DCB, the cath lab. So we brought him back, and there was a recoil that I wasn't able to manage. So if we follow these tips and tricks, you're not going to have any patient coming back in the night or in the following days. You may have restenosis. We can have restenosis like with stents, usually in the first 10 to 12 months. But if not, that's it. You go on.
So as a conclusion, we can say that before using a drug-eluting balloon, we have to reach something like a stent-like result with the normal, simple balloons, and after that, to decide whether DCB or stent.
Well, a stent-like result can be achieved, like, for example, in the first case done in Legnago. I don't think this is something that we need to have, because sometimes it could be a limitation. If you insist too much, in the end you will put stents. So we don't need a stent-like result, but we need a good lesion preparation. But on this, I have a question for Dr. Maksudov. So how is your perception of DCB and the penetration of this technology, not just only in your cath lab, but in the country?
So we're a hospital that we are using a lot of DCBs, mostly in peripheral artery disease, and most of them are with paclitaxel. So our results from follow-up in several years are very good. So we had a very few restenosis. Mostly we are using DCBs in instant restenosis. We haven't used DCBs in myocardial infarction. So I have a question for you, because you're using a lot of DCBs, and how is your experience in using DCBs in myocardial infarction? And do you use coronary imaging before putting DCB over there? And which will be your preferred DCB, paclitaxel or sirolimus, in myocardial infarction?
Thank you for limiting this to myocardial infarction. So, yeah, I think that myocardial infarction is one of the most interesting settings for the using of DCB, also because we have young patients. Putting a prosthesis in a 4-year-old Indian or Bangladeshi patient is not a very good thing to do, I think. So, again, you assess the lesion. If you have a high thrombotic burden, I suggest to try to remove it. With thrombus aspiration or pre-dilatation, whatever. If you have a good lesion preparation, in my case history, I treat it like other lesions. So we don't need to put stents in these cases. But we need clinical data. We have a few studies having assessed the role of DCB in STEMI. One is the PAPA, it's a registry done 10 years ago with good results. Then we have another study, Revelation, but it's still a mechanistic study. So it's a few hundred and something patients, randomized, surrogate endpoint, good outcome at 2 years. I was proctoring at that hospital in Amsterdam this year with Dr. Vos. Nicole Vos is the PI of the study, and she said that they have the 5-year follow-up with very good results. They're trying to publish this. But again, it's a small study. We are planning Piccoletto 8, which will be a study in STEMI and non-STEMI, so all myocardial infarction, drug-eluting stent versus drug-coated balloon, with a clinical endpoint. So I can respond to this question in a couple of years.
Okay, so we can close the discussion as the time is running, and we pass to the next presentation by Dr. Cortese, Life in a Box, how to obtain the best from a DCB angioplasty.
Yeah, we did this Live in a Box a couple of years ago. You were there at the meeting that we had in Italy, but I think it's nice. It's a very complex case managed by DCB with one of my previous colleagues used to work with, Dr. Limbruno. So please, you can play it. It's a cheap case with a patient, a 70-year-old patient, which arrived last week in our hospital for a non-STEMI. We did the coronarography and we showed the 2 total occlusions of the circ of the RCA with a diffusely diseased calcific LAD. So what we are going to do now is to try and attempt a PCI of the LAD and the diagonal branch, which is a highly diseased vessel in a patient which has a high bleeding risk because she had anemia and she had problems with the hemorrhoids which were operated. And then she still has some anemia which we need to investigate. But the patient is unstable, so we need to fix the LAD disease.
In this kind of patient, you are going to use some kind of hemodynamic support, or you are going to perform the angioplasty freely?
Yeah, we need to have some support. So we discussed if to use the IABP or the Impella, and now we are going to use the Impella CP as a support, considering that this vessel is the only last remaining vessel of the patient.
Another question, Bernardo. Did you discuss this patient with the surgeon? Because, of course, from the coronary point of view, it would be also, as I have seen the coronarography before, it would be a good patient for the surgeon, but from the clinical point of view, probably has some other problems, you said me.
Yes, the history of this patient is quite complex. She received a mastectomy for cancer, and so she underwent radiotherapy. She is anemic, and so we discussed this case with our cardiac surgeon, and he preferred to let us go ahead with PCI. So this is why we're going to do a PCI today.
So, Bernardo, how are you going to approach this difficult artery? It seems very tortuous and calcific.
Well, actually, as you have seen, the main difficulties was to approach the two vessels, meaning the LAD.
Can you increase the volume, please,
really
a little bit?
To be managed by the guide wires. So now we're going to see how the disease is, because as we have said before, this patient is very high risk in terms of bleeding risk. So we want to assess the lesion, how it is by means of OCT. And so we would like to spare the metal, at least if not totally, we would like to reduce the entire length of stents. So we're going to use a DCB approach with solution DCB. So this is our initial strategy. And now let's see if we are able to do it.
What about intravascular imaging? What kind of imaging you prefer in this case, this very calcific case?
Well, we have a pretty good experience with OCT because we can see very clearly the lumen and also the calcifications, and we have a good experience with it, so we're going to use OCT now. Okay, so Ugo, as you have seen, we were not able to cross the LAD lesion, the very tight lesion, with a probe, but we were able to do an analysis of the diagonal branch and the proximal part of the LAD. So let's review this.
But as you said, Bernardo, the lesion distal to the diagonal on the LAD is clearly significant. So, and we know it's calcific too. So we don't need OCT there.
Yeah.
We need proximally to the diagonal, because we have to decide how long the LAD must be stented.
If stented.
If stented,
Yeah.
You are right.
Yeah, the lesion is
A
very
lot
tight.
of calcium. Here
Yeah,
is
we have
a little bit borderline stenosis of
we
the
have a
LAD.
co-registration. We can. Okay, so we have this co-registration from the diagonal branch with a very calcific lesion. Okay. So what we aim to do, obviously, is to save the LAD, if you agree, because we have all of the collateral flow to the RCA. So this is a very important vessel. It's a fundamental vessel for the patient. But we also aim to save this big diagonal branch.
So we have to evaluate the stenosis, which is between 35, 37.
Okay.
In the OCT. Is going to be visible now.
Yeah, this is the proximal LAD.
exactly.
Yeah, with a high calcification degree there.
This is the most critical point of the LAD. We have to judge if
Yeah.
it is necessary to stent it or we can treat it in another way,
Yeah.
or not to treat. Okay, can we do a minimal lumen area there?
Let's assess the area. Okay, this is good, and then here starts the disease.
I think
It's a very...
this is the most critical part.
I agree. We have the lumen contour, which is saying 3.67. The area here, 3.33. So it's a very tight stenosis, 3.38.
For a proximal LAD, probably
It's
it's
too low.
below the cutoff.
Yeah, because here we have 7.72, and more proximally here, considering that the circ is occluded, we have 8.4. So yeah, if you agree, I would say that this is a very calcific lesion, so I would treat this. And so we may decide to treat this part of the LAD with this tight stenosis, and then also the diagonal branch, but without touching this part of the LAD, in order to save
So two
metal.
spots stenting, one on the bifurcation and one on the proximal LAD.
Yeah, or stenting or not, I would like to see how the lesion preparation is faring, and then we decide if to stent or not.
But if you are going to use a drug-coated balloon, I don't know if you can cross this kind of lesion. This one and the lesion.
Let's try.
Distal to
Let's
the
give it a try. Yeah, we need to prepare the lesion first, and then to assess if the drug-coated balloon is able to cross. I have to say that solution DCB has a very high trackability and deliverability. So this is not a very complex lesion for this type of device.
It's a sirolimus eluting
Yeah,
drug-coated
it's a
balloon.
sirolimus coated balloon, which was marketed for the first time a few months ago, and it's a very good device. We need also to assess its clinical benefit with the ongoing trials. So we will see it, but the first studies are encouraging.
Let's see how crossable it is.
Yeah. Okay.
So the problem, Bernardo, is that this patient is a high bleeding risk patient, because this bifurcation would be probably treatable at best with a two-stent strategy. But
You must say.
But if we want to avoid to stent in this patient, we have to try alternative strategies, such as drug-coated balloon.
From the literature point of view, I agree with you. Diamo 8, 10. But as per our experience, we have managed this type of lesions also only with DCB. Now the crucial time is now. Now we have to see how this is going. Because you have seen that we have so much of ischemia during the dilatation, because from this vessel, the entire heart of the patient is sustained. Okay?
Very interesting result. It's totally unexpected.
Not so bad.
Totally unexpected, judging the quantity of calcium
Yeah.
which was visible at OCT. And also with angiography, of course.
Yeah. So
you want to try to treat everything with the
DCB.
drug-coated balloon?
We give a try?
Without DES?
We give a try?
I think we can try. We can try, why not?
Ok, la metti di là per favore.
So Bernardo, we will see if these very long inflections necessary for the DCB will be sustained by the impeller about the pressure.
This is crucial. Yeah, we need to see if impella is doing its job, because we have seen just with the normal inflation that the blood pressure dropped to 70.
Before it dropped after only 30 seconds of inflation. How long inflections you are going to perform with this DCB?
Well, we have to tell you, we have to go shorter than
30 seconds?
What is suggested, shorter than 30 seconds.
Shorter than 30 seconds?
Yeah. Well, actually, the first preclinical studies show that also even less than 30 is enough, maybe enough to deliver. But now we want to save this heart. So now let's check the deliverability of this device. 6, 8, 10, 12, 14.
And are you going to finish with the kissing DCB balloon, or
Oh, we
you
don't,
will inflate
we don't need
separately the
it.
two
We don't need it.
vessels?
I would say that we can inflate it separately, and then we assess if we have some plaque shift at the carina. Giù. So we did a 28 seconds of inflation, which is actually not recommended because we usually try to be longer, even 1 minute or more. But in this case, in my opinion, it is not recommendable. So now the inflation in the proximal LED caused a drop in the blood pressure, which was very high.
With ST changes, also at the
ST changes.
electrocardiogram.
Yes, now we have to wait her heart to...
Impella now is going at 4 liters per minute,
Yeah,
almost.
it's what we can achieve from this.
And the recovery is very rapid.
Yeah,
The
this is
recovery
very good.
very rapid.
Yeah. Well, I don't think that we can manage this type of PCR without Impella.
Not at all.
Yeah.
The problem is to guess before which patient really needs Impella.
Yeah, this is the point, also because it's a quite expensive device. Dai, una mano qua.
Sì.
Okay. My blood pressure is raising. It's okay. Now let's wait a second, and then we assess by the angel. Are we going to do a final OCT, or we prefer not to see?
I think if you perform OCT, then you are
Obliged to stand.
obliged to stent, because you will see for sure some dissection, some suboptimal
It will be more
result.
difficult to resist.
And we always said that after DCB, you have to be satisfied of a suboptimal result, because it's going to improve in the next weeks. This is a typical characteristic of drug-coated balloons,
Correct.
to have a suboptimal result acutely and then to
Have a gain.
have
Yeah.
a gain later.
Yeah.
So let's see first of all the angiographic result.
Are we going to
and
do
then
the
we
angel,
decide.
or we can stop here? Let's have an angel.
At least
Yeah,
the
yeah,
angel,
okay.
let's do it.
Ok, ci siamo? Vai.
Beautiful.
Yes.
Angel is
Like it.
beautiful.
I
I
like
don't want to do OCT.
Yeah, I agree with you, Ugo. Now let's see from the right cranial view.
Tufu, Daniele Tufu.
Okay. Okay. Yeah, I like this. Also the flow, the collateral flow is much better. Then we have another thing.
Really, it's improved the flow in the right coronary artery. Very
And we
nice.
have not done any nitrate in the coronary, so this is important. And I have to see another thing, that we have that huge septal branch, which could be occluded if we implanted a stent there. And that is a very important branch for the patient. So I think I'm satisfied of the result.
I agree with you. How long are you going to keep the Impella on site?
Well, usually we may decide to remove it immediately or to keep for a few hours in the ICU. I would say that in this case, we have a very, very fast increase in the blood pressure after deflation of the balloon, so we may also decide to remove it just after a PCI.
Maybe we can try to reduce a little bit
Yeah, now we have to do a weaning.
the output so we
Yeah.
can see if the pressure
Yeah,
remains
it's
stable.
the weaning
even,
that is going.
even a winning action with
Yeah.
the Impella. Also because we want to avoid long anticoagulation. a week on anticoagulation is required by the Impella because we have to keep it, the ACT about 180.
Yeah. But usually
So-
for such a long period, you leave Impella only in case of cardiogenic shock. For
is
PCI
not the
assisted,
case.
yeah, it's not the case. For PCI assisted, you may decide to keep it for 1 day or 12 hours. Com'è qua? Quanto sei? Okay.
2.2, the cardiac output.
Okay.
And the pressure is totally stable, so probably we can remove quickly.
Tanto rimuovo questo. Lasciamolo lì.
Che culo, che è venuto così bene il solo pallone medicato? Non ci avrei mai
Te
scommesso
non mi
una
dai
lira
fiducia.
sopra.
Non dai fiducia al DCB.
Non ci avrei scommesso
That's
una lira.
Italian, but I cannot translate. Ugo, it was a very tough case. What do you think?
It would have been a very tough case if you wouldn't used the Impella because it really helped this time, especially in the long inflations with the drug-coated balloon. The pressure was down, was going very down, and only with the Impella, with the 4 liters per minute of the Impella, we could keep the pressure at the level. Also, I must say you have been very, very lucky because you could accomplish the angioplasty only with the drug-coated balloon. You wanted to avoid the metal and you succeeded. I would haven't bet €1 in succeeding without stent. But actually, with all that calcium, you could.
Yes, you were pessimistic and you told us about this, but well, the case went very well. We were obviously prepared to put some stents, at least some spot stenting in case of large dissections, but the result was good. And I totally agree with you that Impella was really indicated and mandatory in this patient. The drop in the blood pressure was very high. So this was a really cheap patient. And now we will be able to stop the second antiplatelet therapy also after 1 week or 2 weeks if needed, considering the high bleeding risk. And I'm happy for this.
What kind of antiplatelet drug you will stop in 1 or 2 weeks? Aspirin or clopidogrel?
This is a good point. We don't have such data for DCB. As per our experience, we will stop aspirin. And we will go on with only Plavix. That's the only thing that we're going to do.
Very trendy to stop aspirin instead of clopidogrel. Very trendy. I agree completely with you because we learned from the last studies that the antiplatelet drug to be stopped actually is aspirin rather than P2Y12.
Correct.
So I hope this will be the right choice for this patient.
We'll let you know at the next edition of CHIP. Thank you, Ugo. Thank you. Ciao. All right, let's move on to the next presenter. It's my pleasure to present Dr. Amit Munjal from DCB Academy, India. Clinical update on the use of DCB in literature, ISR and de novo. Please, Amit.
Thank you so much, Dr. Bernardo. Good evening, everyone. I am Dr. Amit Munjal. I am practicing at intervention cardiologist in India. Today, I am going to present the use of DCB in ISR and de novo lesions and when and how to use DCB in ISR and de novo lesions. This is on behalf of DCB Academy, and this is by the support of DCB Academy on behalf of Eastbourne investigators. I thank Dr. Bernardo Cortes, who is the chief of DCB Academy and primary investigator for many studies. DCB Academy has fellows from all over the world and who regularly conducts the academic activities under his guidance, and I am one of the proud fellows. Learning objective of today's talk is to know which kind of vessels with the de novo lesions could be considered for a DCB alone PCI strategy, to know how to prepare the vessel, deliver the therapy, and evaluate the immediate results after DCB alone PCI, to know about safety and long-term results. Plain old balloon angioplasty revolutionized coronary revascularization, but it has its own limitations in form of vessel damage and restenosis due to acute recoil and dissection. Bare metal stents were introduced to overcome the shortcomings of POBA, but they leads to the problem of instant restenosis. And drug-eluted stents was developed for instant restenosis, but they had their own complications in form of late stent thrombosis and neoatherosclerosis. This leads to the development of drug-coated balloons. It's not.
Try with the other one.
Yeah.
Just click. Could you pass the second? The next slide. Scroll.
Okay. Yes, okay. Yeah. Drug-coated balloons are medical devices used in angioplasty, which are used in angioplasty, coated with medications. Drug is delivered when the balloon is inflated, and it prevents restenosis. Drug-coated balloons offer stent-free options to deliver the drug to the artery, and it prevents from restenosis. Treatment of ISR. Drug-coated balloon and DES are used for treatment of ISR, either BMS ISR or DES ISR. Drug-coated balloons are proven effective in treating instant restenosis and native small vessel disease in coronary arteries. Drug-coated balloons are expanding to new applications, including treatment of bifurcation lesions, large vessels, and diffuse disease, and in these situations with high bleeding risk. ESC guidelines recommend DCB as a treatment option for both bare metal and drug-eluting stent restenosis. Outcomes of basket small 2 trial suggest that DCB are a viable alternative to newer DES in the treatment of small vessel disease, offering similar benefits without the need for a permanent implant. Here we took in this study 800 patients with de novo lesions in small vessel disease. DCB was non-inferior for MACE at the end of 1 year. We also have data for 3 years which shows similar clinical results. This is another Picoletto 2 study by Dr. Bernardo Cortes in small vessel disease. Here, DCB in small vessels was compared to DES in small vessels. It was concluded that late lumen loss was lower in DC group, and percentage diameter stenosis was similar in both the groups, which was confirmed angiographically. And the Revelation study adds to the body of evidence suggesting that DCB may be a viable alternative to DES for specific patient subsets with STEMI, showing comparable results in terms of patient safety and clinical efficacy. The non-inferiority of DCB observed in N-STEMI patients indicate that DCB could be an appropriate choice in settings where stent placement is problematic or not preferred. Hybrid approach of combining DCB with DES. DES for proximal lesion, DCB for distal lesion. This ensures an overall reduction in stent length, which in turn might be beneficial for lowering restenosis rates. Here you can see distal RCA was 100% occluded, DES was deployed in proximal lesion, and DCB was done in distal lesion. You can see the excellent results after the use of this hybrid approach. Here again, DES was deployed in proximal lesion and DCB was done in distal lesion. You can see the excellent results after using this hybrid approach. Another study, the Eastbourne study by Dr. Bernardo Cortes, evaluated the performance of sirolimus coated balloon for the treatment of any type of coronary lesions, including native vessel disease and instant restenosis. It is a multi-center, multinational investigation-driven registry. started with 990 patients in Europe with the target enrollment of more than 2,000 real-world patients at 35 European and Asiatic sites with a clinical follow-up of 36 months. Target lesion revascularization was 6% for 6% for this instant rhinoceros and de novo lesions at 12 months. Secondary endpoints was angiographic success with no in-hospital events, MACE and bleeding very low at 6, 12, and 24 months. Every single element determining the MACE endpoint. Take-home message is that we can sirolimus coated balloon are safe and efficacious, and we can safely use in long lesions and calcified lesions. Meta-analysis of DADOS trial, 10 randomized control trial, 2,000 patients, and good outcome with DES, and very good outcome with DCB, and very good results with DCB. DCB even offers stent-free option. Meta-analysis of DCB for de novo lesions. Here we combine 14 RCT in de novo lesions on 2,500 patients with a mean follow-up of 12 months. No difference in treatment effect based on the indication, mainly small vessels, acute myocardial infarction, bifurcation, or high bleeding risk. No difference in TLR compared with alternative strategies. At follow-up, at similar minimal lumen diameter and at follow-up similar percentage diameter stenosis. Here you can see the many studies combined together suggest that DCB are safe and effective to use. Safety of, and there is enough data to support the use of DCB. Conclusion, DCB is a new revolution in the field of PCI. Currently, DCB is considered feasible, safe, and effective, which has been validated with several studies and more in progress. The efficacy of DCB is now proven, especially in instant restenosis and small vessel disease with a good safety profile. This is a pic from DCB workshop conducted by Professor Cortez in Bathinda, Punjab, India. Thanks for attention.
Well, we really thank you for these excellent presentations, and also for the contents of the presentation, and also for the time that you respect the time. This is really compliments for that. Now, I don't know what you think, but we can open some short discussion about the last presentation, or yes,
the live case also. If you have questions, please go ahead.
We are good in the time with the time. So some questions from the audience. Yes, very active. Dr. Maksoudov, you something?
Yes, I have a question for Dr. Cortese about your case. Congratulations for a complex case. If you done OCT over there, probably there will be a dissection. And what will be the next step for that, first of all? And second of all, if you leave it like that, for how long, I didn't get it, for how long you put it, adapt over there? And that's it for now.
Yeah, the first question is, okay, you see a good result, you do OCT, you see a dissection. If you don't do OCT, you don't see the dissection, there is no problem. No, I mean, you don't need to do imaging in the end unless you have a big clinical doubt after angiography. So this is our message, because imaging has been associated with an increased risk of doing over-treating with bailout stenting. So we think that imaging is important for lesion assessment in selected cases, left main, calcific lesions, ISR 100%, you should use imaging. Tomorrow, the live case will be with an ISR patient, but in the end, you don't need it. As regards dual antiplatelet therapy, DCB is more forgiving as compared to stents. We have published this year a study, but this is a topic that Fari will face later. In the specific case of the patient, we underwent for 2 weeks dual antiplatelet therapy because of, she had 9 point something hemoglobin, and then we stopped aspirin and we went on just with clopidogrel, and the patient has we have a short follow-up of 3 months, the patient was faring well.
We have a question from Professor Vasilev.
How you deal with the waiting time after balloon predilatation or preparation? Because sometimes, and when you remove the guide wire, they are sealed from guide wire dissections, which practically are visible after removing the guide wire. So usually we are, after DCB treatment, we are waiting without guide wire just for 3 to 5 minutes to see what happens in 2 contralateral projections, because waiting while the wire is in place, it's a different if there is no wire. I say this because I have a couple of cases when everything was looking good with the wire. This is our strategy, and this is obligatory in our cath lab to check into projections at the end of the PCI without guide wire, just because of this sealing effect of the wire while still in place. And we have one for sure, vessel thrombosis after DCB, just a couple of hours after the procedure. With the result, angiographic result, looking quite good, even not so, because to be honest, with this spiral dissection on the right coronary, probably I would not, like Fari, leave this right coronary without stent, but you left it, and you were right in that case.
Also, I'm right.
Sorry?
Also, I will be right if you put a stent there.
Yes, but how, this observatory period, with or without wire in place, because probably sometimes you can visualize something which is missed on the first sight.
It's a good suggestion what you gave. We don't do it because personally I've never had a recoil or worsening of the dissection after the removing the wire. We usually wait for 5 to 7 minutes with the wire in, because if we have recoil, we have to rewire it, and it can create a problem. But as you said, if you had this, I think it's the same, doing it also reassessing without the wire. I think it's a good suggestion.
Dr. Sianos?
Yes, thank you. I saw the entire discussion essentially focusing around safety. Dissection, thrombosis or not, whatever. What about efficacy? And what is the role of physiologic measurements? Because, for instance, can you say from the result that you achieved there that you had a good physiological outcome? And the question goes to the direction including the fact that we see better results after, and all of that is eyeballing. What is the role of physiology in achieving acute result and evaluating long-term outcomes after DCB? Because I've seen many other eminent operators that regularly they are advocating the use of PDPA measurement, at least without even a vasodilatation, in order to assess the acute outcome after the DCB dilatations.
I go?
Yeah, you're an expert.
No, I think that this is a great point. Physiology is getting quite a good momentum for DCB angioplasty. I'm not a big fan of physiology, actually, because we have gathered an experience with angiography which dates back 2007, when we did our first DCB angioplasty. So angiographic parameters, in my opinion, are more than enough in the vast majority of the cases. But still there are cases where you have recoil, you don't know what to do, patient is at high bleeding risk, you don't want to stent, so you have to do physiology. We I convinced also Antonio not to use physiology because, you know, he's a man of fashion. And in March this year at India Live, you were there, he said, hey, we have to use physiology in many cases, but now 2 weeks ago at TCT he's saying that you should use it only in selected cases. As regards clinical data, still it is lacking on the role of physiology with DCB. We are publishing a Piccoletto 2 QFR study, having done physiology in the end, before, the end of PCI, and then 6 months during angiographic follow-up. So soon, this data will provide some more information about the role of physiology. But again, it's not a law, but as per my perception, we should use it only in selected cases.
If I can say something about your question, Dr. Sianos, well, in my opinion, what I am doing, that the imaging, it's good when you put a stent to see how the struts. If you don't have a big dissection in the vessel after DCB, and if the flow is okay, I personally use IFR, the wire there, just to reduce the amount of the contrast, but also to obtain a good value. For me, it's a good solution to use physiology after DCB and not imaging after DCB, because if I see something that is bad, then it's something imaging I use for the drug-eluting stents. Now, if you permit me, I will go with the next presentation of Dr. Cortese, which is DCB in CTO and complex coronary interventions.
This is the last one, so I don't want to bore you. This is really, truly the last one by myself. We are pushing a little bit the things in seeing some cases and some literature about the performance of DCB in a complex lesion setting. Is the one called the CTO and complex lesions. Yeah, it's a very fascinating setting for the use of DCB. Actually, look at this. This is a highly calcific complex CTO. Would you be happy to put, you know, how many? 70, 80 millimeters of stents here? I don't think it's a good solution. Okay. Also because over-stenting or using only stenting has been associated with a short follow-up 1 year in the FAME3 trial to be not to be non-inferior with CABG. And we have to provide the best treatment solution for our patients. And in the complex lesion setting, the data that we have so far are on the side of CABG, if we want to follow this study, which was physiology-based. I took yesterday this study, I wasn't aware of it, because I wanted to see the clinical performance of drug-eluting stents in CTO. There is no study. Nobody did decide to do a big clinical endpoint study on the performance of DES when they came out as compared to POBA or BMS or whatever. So also the literature for DES use in CTO is quite poor. And here you can see in this meta-analysis versus bare metal stent, small studies, but again, no difference in mortality, no difference in MI, a good difference in terms of TLR, but it's not such a hard endpoint. Calcific lesions, this is the last barrier for our patients. Look at the outcome of drug-eluting stents at 10 years. The risk of any endpoint, hard endpoints also, is very bad if we implant only stents in this type of patient. So we don't have with the stents the panacea for all of the lesions. So the same is for very long lesions, very long stenting or small vessels. We have double or more than double the risk of events as compared to a normal vessel, a short stent, because I totally agree with you. If we put in a 3.5 vessel proximal LED an 18 or 24 millimeter stent, is not gonna, if we implant it correctly, the patient is not gonna come back. I'm totally sure about this. But what we do every day in our cath lab is a little bit different. So we started investigating the role of DCB back 9 years ago, publishing this case series showing for the first time how this technology could, at least a good one, could bring us good angiographic outcome. I think that this technology is particularly appealing given the characteristics of working very strongly into the vessel wall for the first weeks. 4 to 8 weeks, this is what we need. We need to counteract the EPC cells recrutation and smooth muscle cells proliferation. That's it. For the rest, we don't need anything. We have seen on the left panel that paclitaxel-coated balloons are associated with lumen enlargement, ranging, according to the studies, between 55 to 75% of the cases, which is very good data. On the right, there is also a study showing how leaving a dissection after a DCB is not only safe, but is associated with an improved penetration of the drug and improved late lumen loss, studied by Yamamoto. And the same group went out with an OCT study. I was a reviewer of that study, and it has been accepted and published soon, showing the same thing with a dissection analyzed by means of intravascular imaging. Amit already showed this. In a small vessel setting, DCB is particularly fascinating. DES is determining this late lumen loss. This is a paclitaxel-coated balloon determining this late lumen loss. But interesting is that, as I said, in many cases, we have a stopping of the events with the DCB, red line below, and DES going on with events which, according to the lesion setting, it goes between 2 and 3.5% per year. Okay, so in a complex lesion setting, again, using a DCB can be particularly appealing. This is our first study showing how leaving a dissection after DCB is safe, because after 6 months, 45 out of 48 dissection did completely heal, and in the 3 not healed dissection actually were not associated with impaired flow. We had 0 cases of MI, 0 cases of death in this cohort of patients. Really recent, accepted 2 days ago, we have shown the same with the Magic Touch sirolimus-coated balloon, showing how leaving the dissections on the left panel is not associated with occlusion, myocardial infarction, and the outcome is similar, with the trends to lower events, but similar to the non-dissection cohort. So also sirolimus-coated balloon is associated with this safety in case of dissection. This is a quite complex case that I did during one of my proctorships this year. Don't remember where, it was probably in India. We tried to do it retrogradely, but we weren't able to do it, so we converted to antegrade. We did the contrary that we should do, but that's the truth. In the end, we were able to navigate through the lesion, okay? Then we started inflating our balloons, still having in mind to use or not to use DCB. Let's see after predilatation how it's working. 2025 semi-compliant balloons. We had this dissection in the proximal part, mostly in the left. Let's see if I'm able to go. Yeah, look at this. This is a nasty dissection. I'm not going to leave that in our patient. So in the end, we have to fix it with a stent. And then the rest doesn't need to have stents, because the result after predilatation is good. So in this case, we use a long 2.5 by 40 DCB, and this was the final result. Very good, fast flow. We don't need to do anything else. We have a very nice study done in Malaysia, comparing, this is a propensity matching study, it's not a randomized study, unfortunately, so far, but comparing the performance between full DES versus a blended therapy, DES proximally and DCB mid to distal part in a multivessel disease. Look at the device length was more than 60 millimeters. In the DCB-based group, 1/3 of the lesion was covered by stent and 2/3 by the DCB. Look at the outcome. Okay, MACE significantly reduced in the blended therapy. This is how we call it, blended therapy. There was also a reduction in cardiac death, which is play of chance, in my opinion, but the outcome was really good. And look at the Kaplan-Meier curve, flattening of the events after 12 months. Again, This is the third or the first study showing this with the DCB, full DCB, or blended therapy with DCB. We have seen Eastbourne with Amit, so I'm not going to tell you something more, but I'm going to finish with this case, which was the first that we showed. It was quite complex to navigate through this total occlusion. We had to use several tools. In the end, we use quite often rotational atherectomy before DCB use, and then we started predilating the lesion. Again, it takes time. Also for predilating the lesion, you should inflate the balloons for some time, and then in the end, you assess the result. If the result is good, or if you don't want to put very long stents, you can use DCB. In this case, we use a blended therapy with some paclitaxel, and the sirolimus in the proximal part of the vessel, according to what our shelves were telling us to do. And this was the final result. Again, you take an orthogonal view here without the wire. Look at this. Very nice result. We don't need to place stents here. But the patient, unfortunately, came back after 5 months for stable angina. The problem here was with the stent placed on the RCA distally, but look at still a nice result on the left coronary system with some recoil. Here we did IFR, and the result was still good. The last frontier can be to use in the very long ADR CTO cases to use a DCB strategy. In this case, we had to get out the true lumen quite proximally. I did this case with Roberto in our DCB, in our Academy for Innovation that we do every year. We were able to re-enter distally, and in the end, again, we place a stent proximally where we have quite a good number of recoil in the proximal part of the CTO, but all of the rest was done with a DCB. The lumen was good. We had IVUS, so we used IVUS, showing that the lumen was good. The flow was fast, so we finished that with a blended therapy. The future are randomized clinical trials with a clinical endpoint. Transform 2 is one of them. Sirolimus coated balloon versus everolimus eluting stent, native vessel disease, long lesions, vessels between 2.0 and 3.5. Clinical endpoint TLF. This study is ongoing. We have enrolled 580 patients out of the 1,800 that will finish the study. So my conclusion, CTO management by DCB requires high expertise. I'm not gonna, if you're not an expert on DCB, I'm not gonna tell you to start with these cases. Of course, in many cases, you will end up with a blended treatment of DES, short proximally, and DCB for the rest of the lesion. Paclitaxel coated balloons are associated with lumen enlargement, which can be particularly appealing in a small vessel disease setting. SCB do not have this characteristic, but they have still a good clinical performance. We will see with the next data. Thank you for your attention.
Well, we're gonna, with the next presentation,
Dr. Fari,
okay,
please, I'm honored to present you again. This is another interesting frontier of DCB for the high bleeding risk patients. Fari, please.
Okay, so this is my presentation about the patients that high bleeding risk and using the drug coating balloon. So the bleeding is important, and the mortality after bleeding at 1 month and 12 months in all the studies have been demonstrated that increase the mortality in the group of the patients that have major bleeding. The difference in this percentage is because we don't have an unique equal definition of bleeding. This is the first thing to do. So if you go further, as I said, there is no universal definition of major bleeding. There are different types, and for example, one of the first used definition of bleeding is the TIMI that was used for the bleeding in the patient after STEMI with the fibrinolysis, and then the GUST is another one that quantifies the bleeding as a major and minor, taking in consideration also the cranial bleeding. And there many trials are using different definitions, combining laboratory and clinical aspect in those patients like cure, acuity, oasis. We see all these studies, they are using their own definitions. Another one which is really good definition of bleeding is the Academic Research Consortium for bleeding, which is a BARC definition, dividing in the minor and major bleeding, that up to type 2, they're considering, you know, this classification. This is a good classification to be used in our patients and also in the different studies. So the major bleedings are from type 3 up to type 5, which is the obviously fatal bleeding. And the bleeding is important because many studies demonstrating the increased mortality in the patients that after the PCI demonstrated a major bleeding. And you see some of these studies comprehending 12 to 15,000 patients. Here, meta-analysis of QUOC is about 500,000 of patients that demonstrates that bleeding BARC2, BARC3 increase the risk of the mortality several times than those without bleeding. And the factors that are associated with the bleeding after PCI are different. These are the physiological, like age, some comorbidities, laboratory, bleeding history, and so on. Identifying clinical, and here it's something that I can say to you, use a kind of a risk stratification before starting a procedure, and to understand your patient in which group is, whether he's at high bleeding or not. Several scores have been proposed for evaluating the risk of bleeding, and among these precise DAPT, DAPT, CRUSADE, and ACR high bleeding risk score criteria are those widely accepted. Here you can see the precise DAPT, the 5 parameters, DAPT, which is the long DAPT therapy after the stent or the PCI, CRUSADE score, and NCDR, which is the American one, with a different parameters. So one of them, doesn't matter which of them. This is the ICI criteria for high bleeding risk. That is major high bleeding risk criteria and minor high bleed risk criteria. And if your patient has even one major criteria, he goes to the high bleeding risk. For example, hemoglobin below 11. You understand? Hemoglobin below 11. And so we need to perform this risk stratification of our patients before starting the procedure. And you see in this is the ACR high HBR criteria. Every one of the parameters, for example, the severe renal disease increased the risk of bleeding by 14%. The anemia increased the risk by 12%. Every one of the components of the risk score is demonstrated in this slide, how increase the bleeding. But once did that, we need to take the strategy. And the strategy are before PCI, during the PCI, or after the PCI, So if you look, for example, during the PCI, we can make optimal hemostasis, the access site, optimal hemostasis, the device chosen. But here the drug-eluting balloon find his place as that simplifies the procedure, and with the drug-eluting or drug-coated balloon, we go to this third step, which is the after PCI, we can reduce the double antiaggregations. So the double antiaggregation after the drug-coating balloon generally is considered 1 month. The European guidelines says even a little bit more, that they talk about 3 to 6 months, but at the end, with 1 month, we are okay with the double antiaggregation. And if you go, this is blocked, I can't change. So some studies about the drug-coated balloon in the high-risk patients, maybe there was another one, debut. This is the first trial, debut trial that randomized, control trial, randomizing the patients to drug-coated balloon and BMS, and they demonstrated that what one-month therapy, but they demonstrated that the MACE were clearly higher in the bare metal group, and for each parameter of MACE that you can see here is higher in the bare metal stents. But the bleeding events were similar, so using a drug-coated balloon in this, those are patients with high bleeding risk, in this setting is justified. Then if we go to the basket small trial, if we take those patients in this basket small trial, those with a high bleeding risk, there were 155 patients, patients with a high bleeding risk had higher mortality at 3 years, and this is clear. And then the rates of major bleeding tended to be lower after DCB than drug-eluting stents. And major adverse events between DCB and death were similar, which means major events means occlusion of the vessel or target vessel revascularizations. If we go to another study, this is an interesting study that is DCB-only strategy with only one antiplatelet drug, single or substance therapy. And this is a retrospective analysis of 7,000 patients. From them, 2,032 were treated with drug-eluting, drug-coated balloon, and from them, 229 were entered in the follow-up group for the 12 months. And MACE was, you see, classical MACE, definition of MACE, and classical secondary endpoint, including bleeding complications, BARC 2 to 5 bleeding. So in this study, тук всичко се блокира. Може ли да минем на следващия слайд, че нещо тук се блокира? Което е жълтия? Това ли е жълтото? Добре, благодаря. Благодаря. In this study that we talk about, it's important that there were no acute or subacute vessel closure. You can see the TLR rate 1.7 in this treatment group. So just one antiaggregation doesn't increase the risk of the vessel closure. Then another got very quickly to this recently published study of drug-coated balloon versus death for the treatment of cancer patient presenting with STEMI. Those are patients at high risk. And they demonstrated that drug-coated balloon had a numerically lower rate of MACE, and patients treated with drug-coated balloon had a trend towards a lower rate of major bleeding events, significantly lower. And then if we go to this study published by Cortese recently, I think several, very retrospectively study that from 1,000 patients, the patients with high bleeding risk were chosen, and there were 107 patients, and their follow-up was after, they looked at the results after 1 month, and there was not the MACE, also with all the components of MACE, was not significantly different between the two groups. So only drug-coated balloon in high bleeding groups does not, with the 1 month DAPS therapy, does not increase the MACE in this group. And after adjusting for confounding factors through multivariate analysis, thrombotic event rates were not significantly different comparing single antiplatelet therapy in high bleeding patients with a drug-coated balloon with standard antiplatelet regimen in BARC bleeding. So this is I think this study it's starting now, if I'm not wrong. Piccoletto, it's starting now. Okay, this is a very interesting study that will take single versus dual antiplatelet therapy in patients with high bleeding risk undergoing PCI with a drug-coated balloon. I think that the therapy was single antiplatelet therapy in this study.
It's a randomized study after DCB angioplasty between a single versus dual.
We'll give answers to the questions because all cited up to now were retrospectively studied. Now this is a study randomized And so, as a conclusion, potentially, that's the most important part of my presentation. Drug-coated balloon is a philosophy. Potentially, every PCI should start with the aim to use DCB only, and after that, to see, according to the result, whether there is a bailout need of stenting. And DCB is a very attractive proposal in the patients with a stable coronary disease that are identified as high bleeding risk patients. Thank you for your attention. Bye.
Thank you, Fari, for this very interesting and comprehensive review on DCB in high bleeding risk patients. I would say much more interesting than the first one, which was quite complex. But I still have the question about polyaglycon. I'm joking. I'm joking. So I don't know if we have time for discussion now, or if we are a little bit over the time. It's 6:06.
6 minutes.
So, are there questions for these two presentations by the audience? Yes, Professor Sianos.
About your presentation, Dr. Cortese, I found the concept of DCB in the CTOs appealing. The reason is that we do that already for 15 years, not in the intentional treatment of not living back, but on the concept of investment procedures. So cases that they have no prospect of success, or there's very extensive subintimal tracking in the vessel, we have been leaving them. And there is a benefit that is something measurable. And you should maybe consider to in that direction, is that how much flow you are achieving antegradely, regardless of what you leave back. And the measurable thing is the reduction of the collateral circulation. So even your first case, I wouldn't hesitate of living without a DCB. What we know very well, and in contrast, and that's my last comment, that you might consider, is that the healing process in extensive subintimal manipulation is completely different from the intimal dissections. And we have seen that for many years, that essentially the angiographic image that you see over time is this kind of thrombus recanalization, spontaneous angiographic image with many multiple pathways within the vessel, rather than the very good, nice angio result that you see when you're doing a 90% dilatation with a DCB. And that's much safer to live. So in that respect, in the context of the CTO, if you can achieve a TIMI3 flow, even in a very extensive dissection, that is something that it is considerable. And we have been thinking for that for a very long time. And the last comment is that about, essentially, in the procedure that you saw, the first one, which if you allow me, I would have said, not even stand it, the proximal RCA. Over there,
which one?
The one from India. You can clearly leave it, because you have one benefit. Nothing will happen to the patient. He had so strong collateral circulation that you expect nothing. In the worst case scenario, it's what you do. You do an investment procedure, you catheterize after 6 months. If it's reoccluded, it's reopened or not, but I have the feeling that they do well. Essentially, what did you do? You stand at the CTO, but beyond that, you do something that we are now considering that I think is very important, is that all the diffuse disease distal from the CTO, we used to leave it for vessel remodeling with TIMI3 flow. Personally, I found it very appealing that you do some gentle dilatations with DCB, and then you are improving the flow or the vessel, but we consider that a little bit as a mechanical vasodilatation in a very diffuse disease. Potentially, this can be done as a second stage procedure. But generally speaking, I think the CTO, it has a difficulty that it requires extensive stenting, and we have to find ways to reduce that. And consider only the fact of the hybrid approach, you might be able to leave it even more, based on the fact that you have the protection of the collateral circulation. It's a field that it is much easier. It has the technical complexities, it has the very troublesome imaging of what you see at the end, but it's much safer.
Okay, you said a lot of things, so we should stay here for hours to discuss, but you said things as an expert and very clever things, I would say. In the end, in the specific case, I would say that with the flow coming anterogradely and retrogradely, a dissection. It was a nasty dissection. I just put one shot, but we did two. I think that would get occluded. The patient had angina, so we would have lost all of the 3 hours that it took for us to reopen that vessel. So I think that we did the right thing in stenting that. But as I said, in the end, we need clinical data. We need clinical data, because also with stenting, we say that we don't want extensive stenting, but we have no data showing the real benefit on doing extensive stenting in CTO, as we don't have reliable data for DCB. So next studies, there are some in the pipeline, some studies we are designing, Piccoletto 3 about this. Hopefully we will have this information. Yeah, okay, so I think we have to close because there is another session. I would really like to thank Professor Vasilev for having accepted us and invited us to do this meeting with DCB Academy. Thank you for the invitation, and enjoy the rest of the meeting, and see you tomorrow morning.